First of all, thank you, Gordon, for the kind invitation. It is a great pleasure to be here in Milan with you. And I want to talk about the internal brace of the ankle again, but an arthroscopic internal brace, which is a little bit different. I think that we talked this morning about ankle instability. And I have to say that a lot of things changed in ankle instability in the last 5 years. And probably some of the things that someone said this morning is not true at 100%. So we know that the Bostrom is the current gold standard procedure to treat ankle instability, but we have to say that probably in the next few years it will change, and we will do an arthroscopic procedure to treat ankle instability, because ankle instability is not just a problem of the lateral ligament, it's a global ankle problem. And if you never treat the rest of the problems, maybe the patient will have problems in the future, especially if you forget to treat deltoid problems that are very common in ankle instability. So the Boston procedure, you can usually do this kind of incisions. You can use this kind of anchors. But, as I said you before, this is a global problem. It is quite common to have intra-articular injuries secondary to the ankle instability, and you have to treat at the same time. That's why it is recommended to scope all your patients when you treat ankle instability. We know that in general population and symptomatic ankle instability, more than 90% of the patients that we treat, they have just an injury of the superior fascicle of the anterior talofibular ligament. So we know that anterior talofibular ligament, you can see here, I don't know if there is a laser here, no. You can see this is the anterior talofibular ligament. You have a superior fascicle and inferior fascicle. The superior fascicle works separate from the inferior one. And this is intra-articular, and this is not intra-articular. And the inferior fascicle and the calcaneofibular ligament, they have these connecting fibers here. These connective fibers, they are strong enough to transmit the tension from this to this and from this to this. That means that this complex that we name the lateral fibulothalocalcaneal ligament complex is a functional unit. It's always tight. Always. Doesn't matter if it's dorsiflexion or plantar flexion, it's always tight. However, when we go to the superior fascicle, it is relaxed in dorsiflexion and tight in plantar flexion. And this is really important when you treat patients. And as I say you before, more than 90% of patients that we treat because of ankle instability, they have just an injury of this superior fascicle. This superior fascicle is an intra-articular ligament, and we can observe here in the lateral gutter when we do dorsiflexion and no distraction technique. So if we can see it, of course we can repair it by arthroscopy. How we do this? We do anterolateral portal, anteromedial portal. The anteromedial portal is usually at the level of the joint line. The anterolateral portal, I will recommend to use it a little bit distal from the joint line. And we use this accessory lateral portal. This accessory lateral portal is at about 1.5 centimeters proximal from the tip of the fibula and just anterior to it. So, to repair the ligament, never use distraction, because when you use distraction, all the capsule will collapse and we will never see the lateral gutter. So, if you want to see the ligament, which is in the lateral gutter, always dorsiflexion and never distraction. And how to do it? Really simple. Through the anterolateral portal, we introduce a suture passer. We penetrate the ligament. There is a nitinol here. We push the nitinol in. And then through the accessory portal, we take out the nitinol. And we change it for a high resistance suture, double in the middle. It was this video was around, but I always use suture tape. So we take the nitinol, and then we have the loop of the sutures in the anterolateral portal, the end in the accessory portal. So from the anterolateral portal, we take out the sutures, the end of the sutures, And then we introduce inside the loop only one of the sutures. I'm sorry for the nails. This is not my hand, okay? So then by pushing the ends, the loop comes down and grasps the ligament. Once you have the ligament grasp, you debride the footprint, and then you perform the tunnel for your ankle. I usually use a knotless anchor. So this is the cannula disc, anterolateral portal. Yeah. So you perform the tunnel for your anchor, and then once you have the tunnel, you charge the sutures in the anchor, and you introduce the sutures in dorsiflexion, which is the relaxed position of the ligament. This way, you make a lot of tension of your ligament, of your repair. And then this is this point that you discussed before about the synovial fluid. It is impossible that the synovial fluid comes between the ligament and the bone because it's really in tension. So once you have this, the ligament is repaired. What is the problem? The problem is we have some limitations for is isolated ligament repair. Of course, if you have no ligament to repair, it is impossible to repair. So in these cases, you need a ligament plasty. But what happens in the rest of the patients? If you have a poor ligament remnant tissue quality, or if you have an hyperlaxity patient, or a high demanding patient, or because in other problems you need that the patient start to move the day after the surgery, it is recommended to augment your repair. You have two types of augmentation. You have biological and not biological augmentations. What is the problem of biological augmentations? You have these two options that you can do arthroscopically. You have the arthroscopic gold procedure, or you have the transfer of the basal ligament. This is another option. What about the gold procedure? So the gold procedure has a big problem. You use the inferior extensor retinaculum, but they are a high level of anatomical variations. And on the other side, from a biomechanical point of view, the augmentation with the retinaculum don't report any significant role in the augmentation of the ligament repair. So you can see here, this is the retinaculum, and the idea is that these are right here. This is the Y shape of the retinaculum. So if you want to do this, it is impossible if you take the real retinaculum, because it's really, really strong, and it will never arrive to the fibula. Even if you do maximal dorsiflexion, never will arrive. So to arrive, you need to have the superlateral band. And this superlateral band is only present in 25% of patients. So all the surgeons that do the gold procedure, they just do the real gold in 25% of the patients. But what is the problem of this band? This is the weakest band of the retinaculum. So probably when you grasp this superlateral band and you make it to arrive to the fibula, when the patient do a little bit plantar flexion, it will never work because it's too weak. So it makes no sense to use the retinaculum to augment the ligament repair. What about the transfer of the basal ligament? So the idea of the transfer of the basal ligament is, you can observe here, you can observe here, this is the distal fascicle of the anterior tibiofibular ligament, which is the basal ligament. It's an intraarticular part of the ligament. This is not real ligament. It's a labrum, has the structure of a ligament, but it's not the real ligament. It works as a labrum. So you can take it out and nothing happens in terms of stability of the syndesmosis. What we have to do here, so the idea, let me see if it works. No, it doesn't work. So the idea is to have this, okay, is to have to grasp this basal ligament, to detach at the level of the tibia with a small piece of bone, and to move distally to implant at this level. So you have the superior fascicle, you have the distal insertion of the basal ligament, which is too close anatomically to the superior fascicle, and you turn down the basal ligament. So what is the problem of this technique? It's possible to do arthroscopically, but the problem is to really complicate technique to do it. So when I have to do this, I just do when I have to do a ligament plasty of the superior fascicle of the anterior tibiofibular ligament, not to reinforce the ligament repair. So my recommendation when you have to augment is to do a non-biological augmentation. It's a really simple and fast technique. How to do this? So the idea is to have your sutures, you have repaired the ligament, and from point 1 to point 2, but extracapsular. So what we do here is, you can see we repair the ligament with a tape, and then we take out the sutures from the accessory portal, and then we introduce again from accessory portal to anterolateral portal, but extracapsular. So we go a little bit back, and by touching the capsule, we progress till the anterolateral capsular hole. So we have a cannula here. This is a good reference to see where is exactly this hole. You introduce again the sutures in the anterior compartment, and you take it out from the cannula. So once you have the sutures here, you go to see where is exactly the talar insertion of the ligament. Yeah. So you have here the ligament. This is the talar neck. And then just anterior to it, you debride a little bit here, and you perform a second tunnel for your second anchor. Here, the most important point is when you introduce the second anchor and you tighten the sutures, you have to make it in plantar flexion, never in dorsiflexion. So you repair in dorsiflexion, but when you introduce the second anchor and you take the sutures, you have to plantar flex. Otherwise, the patient will have problems to plantar flex because of the tension of the sutures. And we need to protect the superior fascicle, which is tight in plantar flexion, not in dorsiflexion. So it makes no sense to tighten dorsiflexion. So once you have the second anchor, you cut the sutures, and that's it. This is 3 to 4 minutes more surgery. So, some points that you have to remember. When you repair the ligament, try to maintain the lateral joint capsule. It is important to avoid to have intra-articular sutures in the ankle, because around 10 to 20% of the patients with intra-articular sutures, they will have reactions against the sutures. Use a suture tape, no round sutures. Round sutures, they have some volume, and most of the patients, when I did in the past, at the beginning, most of the patients, they feel the round sutures under the skin. So try to avoid round sutures. Suture tape is perfect. And use the same suture tape that you use to repair to make the augmentation. Use the cannula. The cannula introduced through the anterolateral portal. This is really important for the technique. It will protect the superficial peroneal nerve, which is the most common risk structure around the area, but you can use it as the reference to see what is exactly the portal, the capsular portal of the joint, inside the joint. Otherwise, it's impossible to see. Everything is white, so it's not possible to see what is the capsule hole. And finally, as I said you before, this is the most important. When you introduce the second anchor and you tie the suture, make it in plantar flexion. So what are the structures at risk of the technique? You can see here, indicated with arrows, this is the superficial peroneal nerve. We can highlight this nerve, and we can see the nerve in this position, inversion and plantar flexion of the foot. We can tighten the nerve and we can observe it. So we usually do the anterolateral portal, as you can see here, just medial to the nerve. Here you have the nerve, medial to the nerve. This is a non-risky position of the portal. If you make the portal lateral to the nerve, you have to go really lateral. Otherwise, the nerve will move laterally when you pass from inversion to dorsiflexion. So this is the less risky position of the portal, lateral, medial to the nerve. So we use this cannula. You can observe here. You have the nerve lateral to the cannula. And then how we can pass in an easy way from the accessory portal to the anterolateral portal. So we have the cannula into the anterolateral portal. We have the superficial peroneal nerve just lateral to the cannula. We have the joint capsule that we have to maintain. And then we have the anterior talofibular ligament. Can you see this? This is in gray, yeah? Okay. And we have the accessory portal. Okay? So we have the anchors and we have the suture. So now we have to pass from here to here, avoid the nerve, and go extracapsular. A lot of things. So we have two options. We can travel our sutures from outside to inside or to outside to outside. Looks like simple outside to outside, but you will see what is the problem. If you go outside inside, you will avoid the nerve. So once you have the sutures inside the joint, you take it out from the cannula, and then the nerve is here, no problem. But if you go outside to outside, look what is the problem. Is you go from here to here, and you have the nerve in the middle. If you go to this direction, probably nothing happens. But if you go to this direction, you will entrap the nerve when you introduce the second anchor. So you have to avoid this and go from outside to inside. This is the best way and the safest way. Once you have the sutures here, you introduce the second anchor, extracapsular, that's it. What is the second problem that we have? You have to avoid to introduce the second anchor inside the subtalar joint. So to avoid this, you have to direct your tunnel and your anchor to the tip of the medial malleolus. That's it. If you direct it to this point, no problem. You will never introduce your anchor inside the subtalar joint. So once you have this is the post-op protocol in these patients. I usually immobilize for 3 to 4 weeks, but every day they take the boot out to make exercises. I usually immobilize not because of the repair of the augmentation, it's because of the patient. Because usually they forget that they have a surgery. Because they have an excellent feeling, the ankle is perfect, and they have the feeling that I can do everything the day after the surgery. And you have to remember the patient, stop it. We need a few time just for biological healing. Usually patients, they start physiotherapy 1, 2, 3 days after the surgery, and formal physiotherapy once we remove the boot 3, 4 weeks after the surgery. So you can see here, this is a patient before the surgery. This is after surgery. You can see how stable it is, the movement. And you can see here one patient. This is a professional football player. He was playing at that moment in Dinamo Zagreb. 7 days post-op. You can see here, this is a basketball player. Probably doesn't work. Yeah. This is a basketball player, 9 days post-op. This is 2 meters, 15 centimeters, close to 140 kilograms. Not bad. He was playing in Bayern Munich at that moment. And this is another professional football player. This is a little bit more than 3 weeks post-op. He's now playing in Netherlands, in the first league. Okay. And what is the difference between repair and augmentation? We present this, this study in the last MIFAS Congress in Rio de Janeiro, and we are writing the paper. This is close to 100 patients with and without augmentation, and we can observe that the main difference between both groups was at the beginning. The first 6 to 12 weeks, there are really a difference. It is much better with internal brace, and in the sports, the distance is even bigger. Less than 6 weeks, 45% of the patients, they can do more activity than the rest of the patients. So, in summary, the augmentation procedure in the ankle is indicated when ligament remnant has a poor tissue quality, hyperlaxity, high diabetic patients. The augmentation procedure allows faster recovery while protecting the ligament repair. And finally, the arthroscopic augmentation procedure is a safe, reproducible technique with excellent clinical results. Thank you for your attention.